So thank you so much for inviting me today to speak to this informed audience, and I've been tasked to talk about hypopituitarism. So my disclosures, I have participated in some ad boards that relate to medications for acromegaly and Cushing's and was a sub-investigator for a growth hormone replacement trial, but none of that will be relevant for what I talk about today. So the goal for this next, 30 minutes or so is to just say what is hypopituitarism and how does it present? How do we diagnose it? And how does it affect people specifically with acromegaly? And then talk about the treatment of hypopituitarism. So just in general, hypopituitarism occurs when there's not enough of one of the pituitary hormones. And this lack of hormone is called a deficiency, and of course that can affect how your body works. And the specific symptoms depend on which hormone you're deficient or missing. And fortunately, there are medicines that can replace all of these hormones, and they help control the symptoms, and people can live very normal lives despite having hypopituitarism. So I'm going to get out this pointer, I think. Yes, good. So just kind of a reminder, I always find like this group is probably more knowledgeable about the pituitary than the average, certainly medical student, but even family doctor that I speak with. But the front of the pituitary is called the anterior pituitary, and it makes most of the hormones and secretes them. The back of the pituitary we call the posterior pituitary, and it releases, they're actually formed higher up, but they travel down and they release two different hormones, oxytocin and vasopressin. And we're gonna, for the most part, talk about all of these. Sometimes this acronym can be helpful to remember these main anterior hormones. So go look for the adenoma, please. So that stands for growth hormone. And then the gonadotropins, which are LH and FSH, and that's what tell the ovaries to make estrogen, the testes to make testosterone. TSH is thyroid stimulating hormone, so obviously stimulates your thyroid. ACTH is the hormone that stimulates the adrenal glands. And lastly, prolactin is the hormone that's important for breastfeeding and increases in pregnancy. But that's just a brief review because the whole purpose of this talk is to go through the various hormones and what it's like to be deficient and how we treat it. There's lots of different things that can cause hypopituitarism. Look at this big list. But for this group, I sort of highlight the things that are in red because those are practically how people with acromegaly can develop hypopituitarism. So it could be just their tumor. Their growth is big enough that it's putting pressure on their gland, it's squishing their gland so they can't produce the hormones normally. It could be because they had to have radiation treatments to their pituitary adenoma, and over time that can lead to deficiencies. It could be the surgery itself unfortunately damaged a little bit of the normal pituitary gland. Some pituitary had to be resected at the time inadvertently, or there was some problems that it got damaged. Or more rarely, but people can bleed into pituitary tumors and they can present quite suddenly with symptoms like terrible headaches, vision changes, but also suddenly become deficient in pituitary hormones. And we call that usually pituitary apoplexy. I know at least there must be the odd person in the room that knows about that. So now to go through a little bit more details of each of the deficiencies. And the first one I'm going to talk about is actually growth hormone deficiency. So you guys know a lot about growth hormone, but always thinking about growth hormone excess. But in fact, we do see people who are deficient in growth hormone. When I talk about all the hormones on the side, that's always going to have this little schematic to remind you that the brain, the hypothalamus, always makes some hormone that goes into the bloodstream and then tells the pituitary to make another hormone. And then that acts on some end organ to make another hormone. And really, at the end of the day, it's the end organ that's important. That's what, if you're low in it or high in it, is going to have you to have symptoms. But in order to have a normal level, these things higher up have to work. So people that are deficient in growth hormone in kids, it's diagnosed easier when they present with, like they're not growing properly. And obviously it's important to treat because without growth hormone replacement, they wouldn't reach their proper destined height. In adults, the symptoms are much more vague, non-specific, and growth hormone in adults is less important when you're low. Some patients, in fact, have no symptoms at all, even when they're growth hormone deficient. But some people feel a bit tired. They notice their muscles are weak. Maybe exercise tolerance is tougher. They have a tendency to increase body fat and lower muscle mass. And they can feel sometimes a little bit socially amotivated, feel a little bit down, and some mood symptoms there. These are really non-specific symptoms. If everybody got tested for growth hormone deficiency that had those type of symptoms, that wouldn't be cost-effective or wouldn't be a good use of resources. But we certainly would think about it in somebody who's known to have pituitary disease. They've already had a tumor that had surgery. They've already had radiation. And especially if they have other deficiencies, then they might have growth hormone deficiency. And we'll come back to how we would test for it. But those are some of the symptoms. Being deficient in the gonadotropins, so remember the hypothalamus makes something, tells the pituitary to make LH and FSH, and that tells the ovaries to make estrogen, progesterone, and produce eggs, tells the testes to make testosterone and produce sperm. So in women who are low in estrogen, they can present with lower libido, menstrual irregularities, in particular lighter periods, missing periods, mood changes, fertility problems, and because estrogen is really important for maintaining bone strength, people that are low in estrogen can have low bone density. So we're not talking about bone pain here, we're talking about weak bones that could break if that's not addressed. Men, many similar symptoms, decreased libido, erectile dysfunction, mood changes, fertility problems. When the balance comes off, tips that there's a lower estrogen and lower testosterone, higher estrogen in men, they can actually develop what's called gynecomastia, so some breast tissue. And men too can be predisposed to have low bone density if they've been low in testosterone. TSH deficiency is hypothyroidism, and we call it secondary hypothyroidism. Many of you guys might have your endocrinologist use that term because it's pretty common to be hypothyroid. Your thyroid itself could be not producing T4 and T3 correctly, and if that's the case, these hormones are low, and then the smart pituitary is trying really hard to stimulate this failing thyroid, so TSH levels are high. So often physicians will be well-meaning and say, oh, I'm testing for hypothyroidism, I'm going to measure your TSH. It's not high, so you must not be hypothyroid. But remember, in the case of hypopituitarism, the problem is the pituitary. So you need to look at the TSH and the T4. And we call this secondary hypothyroidism because it's secondary to a pituitary deficiency as opposed to primary hypothyroidism. It's a primary problem with the thyroid. But as far as symptoms, they're the same, whether it's a problem with your thyroid or a problem with your pituitary. Either way, you could present with fatigue, cold intolerance, constipation, weight gain, dry skin. Those are some of the common symptoms. Being deficient in ACTH will then mean that you're deficient in cortisol, which is the body's natural steroid. And really, out of all of these hormones I've listed, this one is really, the most important. It's vital for life. If you are low in it, you could have, very serious presentations and even be a cause of death. But people that are low in cortisol, the lower it is, the more symptomatic you are. But you could have nausea, vomiting, fatigue, poor appetite, weight loss, a lot of aches and pains, including headaches, low blood pressure, so you feel lightheaded, especially when you stand up quickly. And in general, cortisol is a hormone that helps you recover from illnesses. So if you're low in it, you might find you're more prone to getting sick easily. Or if you do get sick, it takes you longer to recover than, say, your partner or your friend. When you're low in cortisol and it's not treated, you also sometimes can have low sodium levels. That cortisol helps a little bit maintaining electrolytes. So that's how you can present with adrenal insufficiency. And again, it's secondary adrenal insufficiency if the problem is the pituitary. Prolactin deficiency is not an issue unless you're trying to breastfeed. We all have pretty low levels of prolactin, men all of the time, and women all of the time, except for when they're pregnant or breastfeeding. So even if you're completely deficient in prolactin, it's usually not an issue unless you're trying to breastfeed. then you will, of course, have difficulty producing the breast milk. This is one hormone that's a little bit different. Remember, I always kind of pointed out the hypothalamus or the brain usually makes something that tells the pituitary to work, and then tells that end organ to work. In this case, the hypothalamus makes something called dopamine, and that actually inhibits the prolactin, so that's what keeps our prolactin levels low all the time. So if we do anything that affects the dopamine system, then sometimes we can affect prolactin, and I'm going to show you that here shortly. So this is the idea that normally this dopamine comes down from the hypothalamus, so above the pituitary, it comes down that stalk, and it tells you to have low levels of prolactin. Now, of course, you could have a prolactin-producing pituitary adenoma. That's far more common than acromegaly. So if your tumor is making prolactin, then the prolactin might be elevated. And if it's a smaller tumor, the prolactin's usually only a little bit elevated. If it's a bigger tumor, it's much higher. But if you have any big tumor, even if it's something like a meningioma, something that's unrelated to a pituitary adenoma, if it prevents that prolactin from getting down the stalk, your prolactin levels will be a little bit elevated. So it's very common for people who have masses in the pituitary to come with some degree of prolactin elevation. So we see high prolactin a lot more than we see low prolactin, even in patients with hypopituitarism. And in fact, in people with acromegaly, it's probably about 1/3 of patients when they present have normal prolactin levels, and 1/3 of patients, the prolactin is elevated because the tumor makes both prolactin and growth hormone, and then another third, the prolactin is elevated when they present just because their mass is inhibiting this or affecting this normal dopamine inhibition, which we call stalk interruption or stalk effect. So high prolactin is more of an issue than low prolactin. And then the back of the pituitary makes this hormone that helps control the water balance. It's called arginine vasopressin, or sometimes just called vasopressin. It's also called antidiuretic hormone. It's one of those ones that has multiple names that we don't like, right? But if you're low in this hormone, you have something that's called central diabetes insipidus, another name that now we're starting to not like. But when they originally described this, it was because the symptom was very similar to the diabetes that you all know about, diabetes mellitus, or when you have high blood sugars. I think everybody knows when you have high blood sugars, you might present by being thirsty and peeing a lot. Well, people that are low in this pituitary hormone, they also present with peeing a lot and being thirsty, even though their blood sugars are not high. It's nothing to do with their blood sugar. They're just missing this hormone that normally tells them to retain water. And this happens, so they're peeing a lot, even if they're not drinking. So even overnight, people can be up urinating every 1 to 2 hours. They're putting out large volumes of urine. And I think it's useful to know that when you present with a pituitary adenoma, for example, a growth hormone producing adenoma, it doesn't cause diabetes insipidus. It doesn't get to that posterior pituitary, at least very rarely would it present that way. But after you have surgery, you could end up with diabetes insipidus. So that's something that we monitor for closely when people are in the hospital, even after their surgery. So to diagnose hypopituitarism, we've kind of just talked about what symptoms you look for, but what tests you do. I think this is sort of a really important point, and it's good as aware patients, I think, to advocate for this, because I'm telling you that family doctors, well-meaning, forget to do it. But the pituitary hormone is often normal, but it's like inappropriately normal, like it's not working hard to stimulate that end organ. But if they just measure your pituitary hormone, you might miss your diagnosis of hypopituitarism. You have to measure that end organ hormone. So even though it might be tempting to say, okay, I remember that acronym, go find the adenoma, please. I'm going to measure GH, FSH, LH, ACTH, TSH. Those might all be normal, but they're inappropriately normal if your cortisol is really low and your thyroid hormone's really low and you've got no period at all and your estrogen level is 0. So it is a time when you deserve sort of the extra layer of tests that sometimes might not get done if people don't understand sort of the physiology behind it. This one, I know this group will kind of know more about, that IGF-1 in general is a better test than growth hormone when you're looking for growth hormone deficiency or growth hormone excess. So the same is true when you're looking for deficiency. This is an example of a real patient to try to really kind of illustrate this point here. So, I think I've pressed the pointer so much that I killed it. Oh well, oops. I can talk you through this. So this is actually a real patient, but this is not somebody with acromegaly, but this just is somebody I wrote up in the corner as a 42-year-old man who presented with a very large non-functioning adenoma. You know, people that have non-functioning tumors, they often get pretty big before they present, unless we find them by accident on imaging, because they usually present with headaches or loss of vision. There wasn't some clue that they were sweating more, their hands were getting bigger, that kind of stuff. But if you look at the first column where it says pituitary hormone, if you just measured the ACTH, it's 2. That's actually within the normal range. If you just measured the TSH, it's 1. That's actually within the normal range. LH and FSH, same thing. They're in the low part of normal range. Thank you. Growth hormone is pulsatile, so most of the time it's at a low level, and so that's within the normal range. But when you combine it with what I call the end organ hormone, these are clearly low. A cortisol of 50 in the morning is really low. It's usually 200s, 300s at least. And it shows that the pituitary is not stimulating the adrenals properly. And same thing, the T4 is very low, testosterone is very low, IGF-1 is very low. So this person is deficient in all of their anterior pituitary hormones, and we only knew that by doing both tests together. So specifically, like hormone by hormone, to diagnose secondary adrenal insufficiency, the best test is to start by measuring cortisol in the morning. And if it's really low, you know they have adrenal insufficiency, that's confirmed. If it's pretty robust, like above 250, 300, generally we don't have to do any other testing. For adrenal insufficiency, sometimes it's kind of in a gray zone. If it's in the low part of normal range, we're not certain. Maybe they have some degree of adrenal insufficiency. Maybe they are just making enough on a day-to-day basis, but can't make enough when their system's under stress. So maybe some people have had to have stimulation tests done to say whether or not they have adrenal insufficiency. And I'm not going to go into the details of the stimulation tests, but there are tests that are kind of more specialized that have to be done with nursing in the hospital, where we purposely make your blood sugar go low with insulin, and then that should be a stimulus to make ACTH and cortisol. So we see, can you make enough at times of stress? There's another stimulus, we give a hormone that's called glucagon that should make you make cortisol. So we look to see, can you respond appropriately? And then sometimes we do a simpler test that's called an ACTH stimulation test, and it can also determine whether or not you have adrenal insufficiency if the problem's been going on long enough. I think I won't. If anybody has questions about the stimulation test, we can come back to that later, but I think I'll just move on from there now. Because I want to spend a bit of time to make it a bit more relevant to this group. So how does hypopituitarism affect people with acromegaly? Well, there's a number of studies that try to look at the prevalence of hypopituitarism in all comers with pituitary tumors, but as you can imagine, sort of limited data that looks specifically at people with acromegaly. But this was a pretty recent study published in 2022, so I thought it was kind of a nice one to show you guys some real data. So this was from a pituitary center actually in China, but a single center that saw a lot of patients with pituitary disorders. And they actually enrolled 529 patients with acromegaly. And when they presented with their new diagnosis, they collected some information. So this was like prospective. They weren't just looking back at charts. They were following these people out. This is just to show you that most of these patients, 83% of them had bigger tumors. They were bigger than 1 centimeter, which is, as you guys know, unfortunately the case right now, that people tend to have bigger tumors at the time of diagnosis, and of course we hope to diagnose earlier, because then we're going to see fewer problems across the board, including less hypopituitarism. But most of them were macros, and they had pretty high IGF-1 levels, 823, more like what Jill is saying we're used to seeing when people are first diagnosed. look, a lot of them had hyperprolactinemia, 39% of them, and some of that will be because their tumor was co-secreting prolactin, and some of them will because their tumor was big enough to interrupt that dopamine system, so just sort of a temporary thing. They said that it had hypopituitarism if they were deficient in at least one hormone. And again, we had 34%. I don't know if when Dr. Prabtani showed some of his slides this morning, he briefly showed some of the Canadian data of hypopituitarism in the acromegaly study, and it was very similar, something like, I think around in the 30% range, had at least deficiency in one hormone when they first presented. Most of that is being deficient in estrogen women, testosterone in men. You can see that 29% were deficient in those hormones. And actually, when you present with acromegaly, it can happen, but it's not too common to be presenting with secondary hypothyroidism or secondary adrenal insufficiency. It was about 5%. So that is kind of what we see, that there certainly can be hypopituitarism, but it's not by any means everybody has it. The problem that people are presenting with is their high IGF-1 and the symptoms that go with that. And they followed these patients for on average 34 months. They all went for surgery. That was just part of the study group. 50% were sort of cured or in remission from surgery alone, which probably is pretty similar to what we would see. And they did see that there were some new deficiencies after the surgery. So that's one of the risks that the surgeons will counsel you, that there's some chance that you're going to have damage to your pituitary after surgery and need to take hormones that you didn't before. But it also can be a reason to have surgery because we can also see recovery of deficiencies. They take out that tumor and then they leave behind the normal gland, and it can work better after. And that's really what they saw in this study. So here it's just showing of those 39% of people that had high prolactin before surgery, only 1.9% of them have high prolactin after surgery. And what's shown in the pink there is who got new problems. So like less than 1% had a new problem with prolactin. And here if we look at the testosterone estrogen stuff, a lot of the blue is the improvement, and the pink is the ones that never had the problem but then developed it. Still overall better, but just shows how it can change. And then here for the hypothyroidism, a lot of them improve, but some people get new deficiencies. Adrenal insufficiency, a lot of them improve, but some of them get new deficiencies. And this is just looking at the people who have more than one deficiency. So I think it just highlights that surgery, it's quite rare, but you can get a new deficiency. There's a higher chance that you'll actually improve your pituitary function, but definitely a time to retest and look at the hormones again. And this is just showing you that this is not unique to acromegaly. This is just an example of a study of people who had non-functioning pituitary tumors, and they were looking to see how many deficiencies there were. And in fact, 57% of them had at least one or more deficiency. And that's probably what we see, that more often than we see hypopituitarism with our non-functioning tumors, because they're probably even bigger by the time they present. And this was just the same thing. In those people with non-functioning tumors, sometimes they end up with new problems, new adrenal insufficiency, new secondary hypothyroidism, new problem with that water balance. But they also can definitely improve their function over the year. So after they had surgery, the people that had deficiencies, 37% of them got normal, and another 17% it at least improved. So surgery can help the hypopituitarism. This is another place where in my practice I definitely see hypopituitarism in those patients with pituitary tumors, and often it can be acromegaly patients that have tried surgery, have tried various medications, and they needed to go on to have radiotherapy. It's more common to develop hypopituitarism. So, in general, if you look at a lot of studies, probably about 50% of patients develop at least one deficiency over 10 years. And some studies would say even higher. Sometimes when we're counseling patients, we would say, listen, if you're going to have radiotherapy, it's important you do it. Your tumor can't be growing and you need it. You've tried everything else, but know that you're probably going to end up with hypopituitarism, not right away, maybe 2 or 3 years later, maybe 5 years later, maybe even 10 years later. And this was sort of a general statement, but I can tell you Just to give you an example of a couple of papers, this is a paper published from the group from the University of Virginia where they used gamma knife, and it was about 50% of patients got at least one deficiency over 10 years. And this is data from British Columbia that we published, and this is using the fractionated LINAC machine, where it's not the single dose like gamma knife. They choose to give it fractionated here, but really exact same numbers, about 50% over 10 years. So really a lot of people getting hypopituitarism, at least one of those hormones. So now we move to talk about the treatment of it. So the growth hormone replacement, so I know it sounds kind of funny to talk to this group about giving growth hormone, but when you're deficient as an adult, it's sort of optional as to whether or not to take replacement. In general, we would think about it if people have some persistent symptoms, that lower mood, lower energy, lower exercise tolerance, lower muscle mass, despite us trying to optimize everything else, like making their testosterone level as perfect as possible and their cortisol level as perfect as possible. There are challenges to give growth hormone replacement. It's quite expensive, and it's only available right now in a daily subcutaneous injection. There are some once per week sub-Q injections that will be available, hopefully not in too long. But then the other big issue is in British Columbia, it's only covered up until, they're covering it for kids, but once people reach age 21, it's not covered by the government. Many extended health plans will pay for growth hormone replacement if we prove that people are deficient, but it's hard to get pharmacare coverage. In theory, a patient with a history of acromegaly could have growth hormone deficiency, but it would have to be because they had pituitary surgery that rendered them completely hypopit, or more often it's because they had radiation 10 or 20 years ago and their whole pituitary is no longer functioning. And there are circumstances where we would consider giving growth hormone replacement to a person with a history of acromegaly, but you can imagine that doesn't happen too often. And especially now when we're not probably using radiation as much as we used to, now that we have other medications available like pegvisomant and pasriatide that some of the patients that weren't controlled before we're now able to control and may not have to go to radiation as much as they did in the 1990s and earlier. As far as replacing the sex hormones in women, it's really the estrogen that kind of makes people feel better. But if you have an intact uterus, you have to get progesterone with that, or otherwise you'll be stimulating the uterus lining with estrogen, and women would be bleeding all the time, and that would be annoying, but also not healthy for the lining there. Estrogen is available. You could just take it simply as one of the birth control pills, and sometimes, especially for younger women, sometimes that's just easy. It's pre-packaged with the estrogen and the progesterone. Sometimes we'd rather give it in more physiological amounts if people aren't needing it for contraception, and then we can give the sort of natural estrogen, estradiol, either in a pill form or through the skin with a patch or a gel. And like I said, if you've had a hysterectomy, you don't have to take progesterone, but if you have a uterus, you have to take progesterone. And in general, we replace people until the age of natural menopause, so maybe into their 50s, and then we would generally try to wean them off the replacement, just trying to mimic normal menopause, but just like some women in menopause need some longer periods of hormone replacement, sometimes women with acromegaly might want to take it a little longer as well. And then there's kind of two ways of giving the hormones. You can really mimic exactly like the period, so that you just take the progesterone for sort of anywhere from 10 to 14 days each month, and then you'll get a period. Or sometimes we just give both hormones every day, so that you're getting the hormones that you need, but you won't have to have the bleeding. So it's sort of a personal preference and what works better for people. And then there, of course, are some reasons to not give estrogen, like if you've got a history of breast cancer or a history of deep vein thrombosis that wasn't explained for another reason. And then if people are wanting to become pregnant, well, giving estrogen and progesterone doesn't make you ovulate, so then you would have to pursue fertility treatments if you're truly deficient in those gonadotropin hormones. For men, we give testosterone, and the least expensive form, and the one that's covered by pharmacare in BC, and again, it's likely different in different provinces, is by injection. And this is generally every sort of 2 to 3 weeks, probably 2 weeks in most people, but some people can, feel okay for 3 weeks and they prefer not to have the injection as often. And by following the rules, it's given intramuscular, so into like your thigh muscle or into the buttocks. It's a pretty big needle, so a lot of people don't want to do that themselves, so they literally go see their family doctor every 2 or 3 weeks to get this injection. We have a fair amount of experience off-label, instead teaching people how to give it subcutaneous, like into your fat, like the same way you would give insulin or Ozempic, which is a lot easier. It's a small needle. But if you're doing that, then you usually have to do it once per week, so you're giving smaller amounts each week, but that's an option to make it easier. There's also a gel that goes through the skin, but is more expensive, but most extended benefits will pay for it, and it's, can be a lot more convenient for people than having to deal with injections. Oral testosterone is really rarely used. There's one product on the market, but it's not even available in the US. I don't think it's never made it there. But it's not well absorbed through the gut, so men have to take, it's better absorbed with fatty foods. So maybe if you have some high fat meals and you take 4 tablets a day, you might get your levels up a bit, but for the most part we haven't found it to be a satisfying replacement, and that's why people usually aren't on it. And then you wouldn't want to use it if you had male breast cancer, or you have prostate cancer, or you already have high hemoglobin levels, like high red cells, or if you've had a recent heart attack or stroke. If there's no reason why you can't take testosterone if you have a history of heart disease, you just wouldn't want it to be of recent. And again, if you're wanting to have a child, then taking the testosterone is not going to help the sperm counts. You would need other fertility treatments. For the TSH deficiency, that's kind of our easiest one. It's just an oral tablet. It's once per day. It should be taken on an empty stomach. It's called L-thyroxine, or the trade name is Synthroid, common one used. You just don't want to take it if you take iron pills or calcium supplements. You don't want to take them at the exact same time, because it could impair the absorption of the Synthroid, or the L-thyroxine, I should say. If you're completely hypopit or completely deficient, then your dose is going to be about 1.6 micrograms per kilogram. So if you weighed 100 kilograms, your dose is 160. But a lot of people with hypopituitarism, their doses might be lower because maybe they're not completely deficient. And this is an important one. Remember that your TSH is always going to be on the low side, and maybe even if you were the person with it in the low part of normal range, once you start the replacement, it might even be lower. So if people try to adjust your dose based on the result of the TSH, they're not serving you well. That they really have to look at the T4, and we want to target that in sort of the middle to upper part of normal range. Maybe as people get older, we might be happy with low part of normal range. But when you have hypopituitarism, it's the T4 that is more important than the TSH. For the adrenal insufficiency, the replacement is an oral tablet, and depending on which steroid glucocorticoid you're taking, it could be anywhere from 1 to 3 times per day. It's really important to be taught that on your own, to know that if you're sick, you would naturally make extra cortisol, and if you can't do that, on your own, then you have to do it with your medication. So for even a little mild illness, we would say right away double your dose, and if it's a more severe illness, maybe with real chills and fever, you would triple your dose. And if you're throwing up and every time you take your hydrocortisone it comes back up, then you've got to get an injectable dose in the hospital. And we encourage people to keep at home a little injection kit, especially if they live far from the hospital, or they do remote camping or hiking, or they're traveling outside of the country, so that in an emergency you could self-inject into your muscle and at least allow you time to seek proper medical advice. And unfortunately, it's not a nice EpiPen type device that you are dealing with a syringe and then a separate vial, but pharmacists can usually show people how to do it. Because being low in cortisol is so important to know at times of emergency, we'd like people to have a medical alert bracelet or necklace that says they have adrenal insufficiency. So if they were found at the site of a car accident unconscious, a paramedic or a person in a hospital would know that one of the important things is to give them an injectable hydrocortisone, because that's going to be an important part of their treatment plan. There are different steroids. We almost always use hydrocortisone now because it's the most physiological, but there are some circumstances where people are still on cortisone acetate, which is just kind of one step to make it to hydrocortisone, or there are some other steroids, which, you know, in theory could be once per day, which sounds good, but they're probably not as physiological. So if you can, it's better to take the hydrocortisone and try to mimic the normal body as much as you can. And what that is we should make cortisol in the early morning hours before we're even up out of bed. So we wake up with a nice high cortisol to get our day started. And then our levels sort of drift down throughout the day, and we all have quite low levels at night, or we should have low levels at night. So the replacement, we're trying our best to mimic that. So that's why hydrocortisone is best given in 2, sometimes even 3 doses. So for example, you know, it might be pretty common to do 15 milligrams, 1.5 tablets in the morning, and then, you know, about 6 hours later, maybe to do a half a tablet, just so you kind of maintain this a little bit longer, but allow your levels to be low when you're trying to sleep. And as far as the dose, you know, we know the average adrenal probably makes between 10 and 25 milligrams of hydrocortisone per day, and to some extent it depends how big you are. So there's calculations you can do with your body surface area. But, you know, for the most part, people are on 50 to 20 milligrams per day in these 2 or 3 divided doses. So I would say it's quite common for people to be on 10 or 15 in the morning and 5 in the afternoon, or some people find they just feel better if they do 10 in the morning, 5 at noon, and 5 at 5 p.m. Measuring the cortisol is essential to make the diagnosis of adrenal insufficiency, but then to say if you're on the right dose, it's not helpful, because if you just measure your cortisol before you take your hydrocortisone in the morning, it's going to be low because you haven't had your dose since, you know, 12 hours before, and you're wanting your level to be low overnight like everybody else. And then whereas if you measure your level after the cortisol, that's just telling you about that one little snapshot in time. Like once in a while I do that because maybe we're worried someone's on kind of a high dose and should they be on less? Maybe they're not absorbing it well. So instead of reducing it, we check to see how well they're absorbing it. But for the most part, we just kind of work with that 10 to 25 milligrams per day and then just see what's the minimum dose that people feel good on. And people sometimes feel good on higher doses, but they don't want to stay on that because that won't be good for their bones, or it'll promote weight gain and diabetes and high blood pressure. So this one is a bit clinical, like figuring out what we think is safest for you, as opposed to like the thyroid. Oh, the blood test shows this. That's probably a good dose for you. And then for that diabetes insipidus, there's also like a medication that can replace that if you end up being deficient, say after your surgery. Often after surgery, it's transient, and you might only need treatment for a couple of days or a week. But if it ends up being permanent, we just give you this medication, and then it controls that thirst and urination. We make sure people don't take too much of it. It can be tempting to just take a whole bunch of desmopressants. You don't have to worry about peeing when you're out for the day, but then you're going to retain water, and that could drive your sodium level low in your blood, and you can feel quite sick when you have low sodium, and it's even a risk for more serious things like seizures. So you don't want to overtreat, just enough to control that thirst and urination. And it's given by either a nose spray, or there's an oral tablet, or there's like a little melt that goes under your tongue, or there are injectable forms that can be used if you're admitted to the hospital. So just kind of depends what your preference is on which way you want to take it. And this is the last slide before I do my conclusion, that just to kind of highlight, I'm not going to go through all of this, but just to show like all of these replacements interact with each other. So if you're started on one replacement, it might affect your dose of another replacement. And so that's just something that has to be, other doses should be reassessed or rethought about if one dose has changed. Like, let's just give an example. If somebody's actually growth hormone deficient and I start them on growth hormone replacement, it might make them need a higher dose of hydrocortisone. So I need to be aware of that and be thinking about, are they having symptoms of adrenal insufficiency? Or, you know, another one that can be relevant to acromegaly people in a different way, but if you're started on estrogen, like if you're given estrogen replacement, it can actually lower your IGF-1. So people who take estrogen, especially by mouth, they might need higher doses of growth hormone if we're replacing them. But why it's relevant to here is, I think maybe you talked about this at a different meeting, that estrogen can sort of help lower your IGF-1. So if you were on the birth control pill because you just needed it for contraception, and you reach an age and you stop it, sometimes your IGF-1 goes up, like your acromegaly control is not as good. Or sometimes when women go through menopause and they go from having just normal estrogens to low estrogen, sometimes their acromegaly control is not as good because estrogen helps lower IGF-1. Estrogen is a treatment for acromegaly. It's not one that it's not a potent treatment, but it does lower IGF-1 to some extent. So just an example of things always interacting. So this is my just sort of take-home points, things to kind of emphasize that acromegaly, all acromegaly patients, really regardless of the size of the tumor, just get a baseline, should be tested for hypopituitarism at the time of diagnosis. So that means do the TSH and the T4, do the AM cortisol, do the testosterone, just the whole gamut. And it's going to be quite often that you find a high prolactin or you find a low testosterone, or people with acromegaly are presenting with menstrual irregularities. Maybe they've missed their periods and their estrogen is going to be low. You should still look for adrenal insufficiency and hypothyroidism, but fortunately we're not going to find that often with acromegaly when you first present. It might be more like 5-10% of patients. And then, like I said before, to look for the hypopituitarism, you've got to measure that end organ hormone, not just the pituitary hormone. And because you might get a new deficiency after your pituitary surgery, about 6 weeks, we would generally repeat all the tests. Some centers might do that 3 months later, but just somewhere between 6 weeks and 3 months after your surgery, recheck. Maybe your pituitary was fine before surgery, but it's not fine after. And then especially if you've had radiation treatment, even just once a year forever, almost, you should be looking for hypopituitarism at least for 10 years. Then it might just depend more on symptoms, but there's a really high chance of getting deficiencies in some time in the 10 years after radiotherapy. And then if you're an unlucky person that had hypopituitarism before surgery, reevaluate things, not necessarily at 6 weeks, but several months later or up to a year later, the pituitary could recover. So if there's a chance you don't have to take hydrocortisone for the rest of your life, you want to know that. So the endocrinologist should kind of help you in some way to retest your pituitary function in that first year after your surgery, because maybe, there was a pretty decent chance that you were going to have some recovery there. And for your steroid replacement, we really want to keep it like physiological to avoid side effects. And then my other sort of last take-home point is just really remembering, because we see it happen so much that people get their TSH checked and not their T4, and then somebody changes your dose, and it's just a big hassle that your dose should be adjusted based on T4, not TSH. And that concludes what I've got.
So does anybody have any questions? Oh.
I actually have a comment and a question. The comment is, I really love that you told the patients that once they've had radiation, they need to be tested for hypopituitarism each year. Mm-hmm. In the U.S., I can't tell you how many patients have radiation and they're not tested. Mm-hmm. And they come to our discussion groups, and I have to say, you need to talk to your endocrinologist about your cortisol levels and have them tested. Mm-hmm. And they end up having SAI. Mm-hmm. And it's life-changing for them once they start seeking treatment. So I applaud you for saying that.
Well, I'll tell you, it still happens here in Canada that sometimes I'm like, oh, this poor person is probably being hypopit because mm-hmm. it happens slowly. You think, oh, these are so dramatic. People are going to present. But it happens slowly. The levels just drift down, and people just think, oh, I thought I was getting older. I had more joint pain. I'm more tired. And the good thing is when we replace them, they're like, wow, I feel 10 years younger.
Yeah. Yeah, it makes such a difference.
Yeah.
Also, in the USA, they not only do TSH and T4, but they also do T3. Do you not look at T3 here?
We can. So I don't look at it too much. Like, there are circumstances I do measure T3, but in general, T4 and T3 correlate. So if you have one, like, I'm okay with that. Often we do just get the full profile with all mm-hmm. three of them. But if you're trying to be a bit cost saving, that's a place where, like, normally your body converts T4 into T3 mm-hmm. on its own. So if you have either one of the measurements, it should be a pretty good indicator. So sometimes it's done, but I would say less routinely.
Mm. Okay, thank Thank you.
We do it more routinely, actually, when we're looking for hyperthyroidism, like in a different circumstance.
I have SAI. I had my tumor removed about 30 years ago, and it was in the U.S., and at that time, the doctors, as you were saying, weren't over stressing it, but when they tested me and they said, okay, you have it, they told me that when you're sick, you have to updose, but there's no guidance for that. So, you dig through and you find something from the UK or something, but in Canada, do we have anything when my daughter got married, it's a really happy time. All of a sudden, I'm crashing on the car, and I'm feeling the problems that I have when I start having my adrenal crisis. And it was a happy time. It wasn't like you're sick or anything. But is there guidance for people to understand that maybe if your daughter's getting married or your son's getting married or something really happy is going, you might want to updose?
Like a stress. Yeah, it's such a hard thing. And a lot of different physicians have a little handout that they might give with general instructions, but that's going to be more that double the dose, mild, triple, receive injectable. Sometimes I actually sometimes direct people to the Canadian Addison's group, because they have some, even though it's different, Addison's is primary adrenal insufficiency, but they actually have some pretty good information about recommendations for stress dosing and things like that. But your question is such a hard one, what to do with the sort of more emotional stress, or like sometimes university students have asked me, should I take more when I'm studying and when I'm writing an exam? And like for the most part, the answer is like, for the day-to-day stress, almost no. Otherwise, you're going to be doubling it all the time. You're going to have high blood pressure. But I said, like, sometimes an emotional stress can almost become a physical stress. And then, yeah, err on the side of taking extra. If it's just 1 or 2 days, it's never going to hurt you. So if it's some really big exam, you're all day and you just want to take an extra half of hydrocortisone, that's not going to hurt you. Or that seems like the same analogy, big, huge life day, your daughter's wedding. Or one example I give, okay, a death in the family. It's an emotional stress that can become a physical stress because maybe you're up all night and you're not sleeping. And, the consequences of too much steroids are if you're doing it too often, you're going to get the side effects. But if it's once or twice a year, if you're not sure, better to do it than not do it. There was some interesting study, though, that had looked at people that truly had adrenal insufficiency, and then they had them do like mental tasks and saw them like almost like little exam question type things, and said, did they do any better if we gave them a little extra steroid versus not? And they didn't do any better with the extra stress. So I kind of highlight that sometimes to people to say, like, just everyday life stressors, maybe resist the temptation to extra and keep it for the weddings, the deaths, really, sometimes it's just a learning curve. It's like someone like me, you almost have to experience it, right?
Right. And the part I always thought my wife had a cast iron stomach, and I just would get food poisoning all the time.
Right.
I have found out, we look at it, these were stressful times. My job has taken me to Egypt, Libya, to Iraq. So I have a very stressful job, or I did, I'm now retired.
Right.
But I noticed that I would get sick and my wife would be perfectly fine and we're eating the same food. And then all of a sudden, I started when having a situation, updose a little bit, and I do fine.
Yeah, that you learn, and you're right. So go on your
But
symptoms.
the doctors don't even tell you that. I'm
Yeah.
thinking, I must have a weak stomach and get food poisoning all the time.
Yeah.
My doctor never told me that, if you're getting throwing up or getting sick, it might be related to it. But again, that's 30 years ago in the U.S.
No, it's still the same. I think that it's, as you know, there's so many things to cover that, but it's the one that is probably the most important to cover. There's people who present and they die because they didn't have proper treatment for their adrenal insufficiency. So especially if you're feeling nauseated or vomiting, no one's going to ever criticize you for taking it, right? It's better to take it than not.
So, and can I say that whenever you're in a crisis, your mental capacity to prepare that shot is not there. There's a protocol to prepare that shot,
Yeah.
and I have had adrenal insufficiency, and there is no way, and I think that I'm very capable, that I could have done that shot. If my husband hadn't been with me, I probably would have died.
Yeah, so that's a good, I think, to hear it right from you
Yes.
is really meaningful, that we need to make sure to say, listen, have somebody close to you learn how to do it, or just get them to call an ambulance. I know that's also a controversial thing. I don't know what it's like in the U.S.
ambulances don't know
And
about.
apparently, in a lot of provinces, they're not allowed to give steroid, even if
That
the
is-
diagnosis is made. But they've made some progress in that if the patient carries the diagnosis on a medical alert bracelet and they have their own injection, but it's just starting to happen.
So-
Certain provinces do it and certain don't.
I know someone that went to a pituitary center
Yeah.
and to the ER, and they made the husband go home and get the shot and come back in order to give it to her. I mean, the endocrinologist was blown away.
Yeah.
But the whole thing is, in the UK, they say, and I don't know if it will make a difference or not, but that patients that are dealing with this need to ask them, if you're in the right frame of mind, I want you to sign a document saying that you're refusing life-saving treatment for me. And they'll typically give the shot because it won't kill even someone, but it'll save someone's life if they do need it. That's what they've said in UK talks. But in the US, and hopefully it's much better here, ambulance people don't know about low cortisol. And I wish that I had gone over with my husband, because my husband grabbed my emergency injection and he was like, I don't know how to do this. And it took everything that I could even have in me, because you don't have any energy at all to say, read the directions. And, there's no way that I could have done it myself.
It's a good take-home point. Make sure, like, a close family, as many family members as possible, learn how to do it. I always say when it's about to expire, usually their shelf lives are, 2 or 3 years, and hopefully you've never used it, so you're ready to throw it out. But don't throw it out, like, play with it, like, mix it, inject it into an orange, and after you've done that enough times, because hopefully you've never used it, then I say, put it in your earthquake kit here, we say that, or whatever, your emergency kit, so that, because it's not like one day it works and the next day it stops working. It's better to have something expired than nothing at all. But I really wish they had a better product. But you know what the problem is? It's like acromegaly. The market is not big enough. Even the adrenal insufficiency market is not big enough for them to make a nice little Ozempic type pen. Yeah.
All right, I think we're good to wrap it up. One more question. Sorry, go ahead, Nikki.
I have a couple comments too, just based on what went on between you and Jill. So Ontario, and I believe it was actually the Addison's page in Ontario that just posted it. So I think Ontario ambulances do now carry Solcortif and can
Okay,
inject.
that's good.
Circadian dosing. Do you have any thoughts on that?
I mean, some of it's a little bit trial and error, but I guess basically what she's asking is, we want to try to mimic the normal circadian rhythm, and that's to make more first thing in the morning, early hours, a little bit of extra in the afternoon, assuming you're not a shift worker, and have low levels at night. And there was all these, like, hope that there would be products that would come out where you could, and maybe Jill, maybe you guys have them there, but we don't have it in Canada, where you take something and it has like a slow release kind of where you get a little burst and then you get a second little burst, which would be great. But for now, I just say, take your first dose as soon as you wake up in the morning. The product monograph might say you have to take it with food, but these are just replacement doses. It's not like taking steroids for asthma, arthritis. Many people are fine taking it with a glass of water and no food. But some people even say if they're having trouble, like, I'm so lethargic in the morning, like I just don't feel good getting out of bed. I even say just keep your hydrocortisone at your bedside table, and if you wake up or you set an alarm at 6 a.m., you might even want to take your dose and go back to sleep if you normally wake up at 7, to try to just get the first dose in as soon as possible, or at least don't wait till you have breakfast at 10 a.m. Get it in soon. And then some people definitely feel better with the 3 times per day dosing over 2. I have the odd person who wants to do 4, and I think that starts to get to the, ooh, are you just going to forget to take, and it's more of a nuisance. But if they want to do it, I'm okay with it.
Okay.
And we don't have any pumps available here. I think that's something that's, I know at the NIH they've had trials about trying to use hydrocortisone pumps, but again, it's practically, it's probably not going to come to clinical medicine,
Okay. And I heard you say something about self-testing. Did I misunderstand that? Or is there a way for me to test my cortisol levels at home?
No, I must have said it's something that you...
Okay, sorry.
Yeah.
Um,
Like I said, I would say in general, because everything we're always measuring. What's your IGF-1? What's your T4? Cortisol's the one we don't really measure. Once you're adrenal insufficient, we just go by your symptoms and what we think you should need.
okay.
Yeah.
And I completely agree with Jill's statement. I believe I had a crisis in the summer. It was the first time where I went from completely normal to completely not okay. I went into cold water and my body did not adjust at all. I had a friend with me, and if I hadn't had a friend with me, I probably would have drowned. So that, yeah, that's interesting.
It's really scary, and it's, we kind of, I think we as doctors, we need to do a better job of emphasizing, because most people go without having an episode for a long time, and then they have it and they never forget it, right? Like
Well,
are
and there's
never
a
going to
low,
go.
right? Like I will stutter, I'll be sick, I don't really make sense when I talk, I ask a question, but none of it comes out properly right now. I just took my pill. And yeah, there goes my train of thought. I'm sorry, could you repeat what you just said?
Well, just that we need to do a better job of educating about the importance of...
Yes, because that's what my doctor said to me. If you were in an accident, you might not be able to give your name. And I could never comprehend that until the summer, where I realized that there was no, I was just there. And my body was just reacting, and my brain was not at all. Okay, thank you.
Wonderful. Okay, thank you so much, Dr. Johnson. Really appreciate your time today.